Okay, awesome. So you can see the title slide right now?
Mm-hmm.
Awesome. Okay, it's like magic. So it's just to share that it's cancer as a chronic illness that I want to talk about today. And then we'll talk a little bit about care plans. And I know you're working on a care plan, so hopefully that's timely. Let me see over. Okay. So I wanted to do just some personal disclosure. Nobody pays me to talk, so I'm not a member of a speakers bureau. I'm a member of the Scientific Advisory Board of St. Baldrick's, which you might have heard of. They're the ones that do all those shaving events to raise funds for cancer research, primarily pediatric. And then I thought about this, and I thought, no, I will disclose this, that I am myself a cancer survivor, and we'll talk about using that term and the mixed messages of it. So I wanted to just go over the various definitions of survivorship and then talk about some of what's the same and some of what's different about childhood cancer and adolescent young adult cancer and cancer diagnosed in adulthood. And then looking at that whole chronic illness concept, you know, there are lingering side effects from acute treatment, there are late appearing side effects, and then there's the whole issue now of extended treatment. So, you know, not being done after 2 years, 5 years, or whatever. And then to talk about follow-up care and the summaries and the care plans, and then a little bit about challenges that are not future challenge, they're challenges right now. So the definition, at one time, the top bullet point was really kind of a dominant definition, sort of the period after you finish cancer treatment until it either recurs or you no longer alive. That's not considered current. The other thought is that it encompasses lots of transitions. So I've sort of got the pediatric ones here, and I should have said that. I'm a pediatric person for the last 40 some years, so that is the lens that I see oncology through. But anyway, it encompasses transitions for pediatrics from pediatric to adult care, from acute to chronic care, and then from, you know, subspecialty care to primary care. So some of those are also true for adults. But the definition that really kind of is the dominant one now is that one that's highlighted. And that's an individual is considered a cancer survivor from the time of diagnosis through the balance of his or her life. So not waiting until treatment is finished, but from the moment of diagnosis. And so when I sort of did that disclaimer about being a cancer survivor, part of that's what this woman, Katie Costco, said, that that's not a word that a lot of people are comfortable with. And why is that? I mean, she says it feels so contrived. People are still dealing with the reality of being diagnosed with cancer, and they don't know that they're going to survive. So claiming that is not really empowering to people, especially in early stage disease. I thought she made a good point. She said that, you know, there really needs to be a word in between patient and survivor, so that you're not so disempowered by being called a patient, but you're also not running across the finish line with your arms up, you know, saying yay, to be called a survivor. So just to be aware that not everybody welcomes that terminology. Nevertheless, the picture here is of a physician named Fitzhugh Mullen, and he, along with a small group of other people in 1985, first used the word survivorship, and, you know, to really apply to people that had been affected by cancer. Before that, and we'll talk about this in a minute, that we knew about late effects. We knew, you know, we had seen what happened to our patients after treatment and so forth. but nobody really referred to it as survivorship care. That really came with Fitzhugh Mullen. He is deceased now, but his legacy, along with the organization that he founded, the National Coalition for Cancer Survivorship, really made huge strides in this whole field. And he wrote a piece in the New England Journal in 1985 called Seasons of Survival. If you ever get a chance to go back and take a look at that, it really is a milestone in survivorship in the whole field. He knew as a physician kind of what this all meant, but he was one of the first healthcare providers to really speak out about what his experience was on the other side of the bed rail. One of the most important things he said was that what he called the Humpty Dumpty idea of being as good as new after you finish treatment is really appealing, but it's just not accurate. That no matter what, once you've had cancer and been treated for it, no matter what happens, that experience changes you. It leaves an impression. So he was a really remarkable person and quite a pioneer. But now I will do my plug for pediatrics. So the real roots of survivorship care are pediatric. And here's what happens if you stay in a field for a long time and you save stuff. So this is from the time I first went to Children's Hospital to work in a field that wasn't even named yet. And by that, I mean oncology. There really wasn't even a subspecialty of pediatric oncology nursing, let alone survivorship care. But the physician who hired me was named Myron Caron, and he was a real Renaissance man and thought very creatively. And so I went back into my sort of storehouse of files and things. And I don't know what people will do when electronics are the only files we have, but so I went back in and looked, and I thought I remembered a memo from him. And indeed, he had written a preprint of a paper that he was going to be presenting in Paris. This was 1973. And he talked about, barely being able to get 50% or more survivorship after acute lymphocytic leukemia in childhood, and we'll talk about what that is now. But that's where they were then. And he said, if we could improve that, we always said we would jump for joy and treat the long-term complications. So he was one of the first to recognize that there were long-term complications, and said that we have reached that time. But we can't dismiss these long-term effects of therapy. So that was 73, significantly before there was really anything called the survivorship movement. Kate, interrupt me anytime you want. Don't let me just drag on here. But this is, I think, really impressive. As of the most recent data we have, it looks like there are about 16.9 million cancer survivors in this country, and that's about 5% of the population. So that includes both survivors of pediatric cancers and cancers that occur in adulthood. Sort of sad to say, more than 40% of people born today in this country will be diagnosed with cancer at some point in their lives. So if you look at the lower part of that slide, in 10 years, in 2030, they forecast a 31% increase in the number of survivors. So that's good news, but it's also kind of incredible news in terms of what that means for meeting the needs of all of these people. So this one, it's a little bit small to read, but it's the top half that's important. So if we look at adult cancer survivor numbers, in the middle of the line that runs right horizontally through the middle of the slide, just above that shows you that for males, there's about 8 million, almost equal females 8,780,000. Sorry. And just to give a picture of the things that are kinds of cancers that are most common: prostate, breast, colon and rectum, and uterine corpus. Melanoma of the skin is up there on the top 4 for males, as is urinary bladder and thyroid for females. So I think this makes an important point that's not obvious necessarily on the slide, and that is this is going to change drastically, I think, not in terms of numbers, but in terms of how we classify cancer. Because, as you know, now we're talking about genetic breaks and, what are the particular genetic dysfunctions. And I really think that within the next few years, we're going to start seeing lists that go by these genetic anomalies, not by the site where it appeared. Because now, as they analyze some of these on these GWAS studies, the genetics studies, they're finding that some of the breaks and dysfunctions are the same between cancers that occur in adults and those in pediatrics, but they've been described as different entities and treated differently. So it's going to have, I think, big implications for both how we treat and what the possible long-term complications may be. So if we look at peds, 5-year survival rates for ages 0 to 19, the main message I think here is how positive overall most of these survival statistics are. You can tell, though, it's not one monolithic thing. So, for example, AML, acute myeloid leukemia, still has a pretty poor prognosis compared to something like Wilms tumor at the bottom of 96.4%, or Hodgkin lymphoma. So there are some tumors, solid tumors in kids, that are still lagging behind in terms of survivorship compared to some others. So we've gone overall in 40 years that I've been involved in pediatric oncology, we've seen it go from 10% to nearly 90% survival. But as I just said, survival rates for some are less. And then that 16.9 million includes 375,000 who are adult survivors of childhood cancer. So that's the difference in numbers between adults diagnosed with cancer and kids. For kids, it's still a rare disease, thankfully. However, it's important to point out that the average age at which a child is diagnosed is 4. If you add all those kinds of cancers together and take the average age of diagnosis, it's 4 years old, approximately. So if you think about how many years of life are saved, if you save a child's life, on average, that's about 70 years. So it's significant beyond this pure total number of cases. However, 60% of children who survive at the present have devastating late effects. And those can include, we'll talk more about this, secondary cancers, infertility, and on and on. So this is a slide that just really looks at that. So a few years ago, there was an article published in the New England Journal that documented that about 2/3 of long-term cancer survivors had at least one late effect, and about 30% had late effects that were severe or life-threatening. So this is serious, and treatment is evolving. So we're not saying this will be the way it is for all time, but this is a serious thing to contemplate in adult survivors of childhood cancer. The other thing that's really concerning is that those curves don't come down. So the incidence continues to climb. Why would that be? Well, if you think about adulthood in general and the incidence of chronic conditions. I mean, we're thinking so much about this now with COVID and comorbidities, but, as people age in this country, the incidence of things like hypertension, diabetes, cardiac disease, and so forth goes up. So if you already have this vulnerability because of your childhood cancer experience, that probably is what's contributing to that. So overall, this is kind of a summary slide of all the possible late effects, and yet it's probably not inclusive entirely. I'll say now, and I'll make the point again, I think one of the most important things that I've learned, and our cancer survivors have taught me this, is that we're continuing to learn. And if we don't listen to what patients say to us, and if we don't elicit what their experience is, we may miss out on, what's really happening after the introduction of for example, a new immunotherapy. Down the line, we don't really know what's going to happen. So to me, this just always illustrates, it's important to listen to the patient and to ask the patient, what are you experiencing? One of the things that I've experienced that I think is really frustrating is that in many, many settings, we're using now a distress scale, and, which is wonderful, except that frequently, I think now, what I've seen is it's the MA in the practice who is standing in front of the computer and kind of looking over their shoulder saying, and, are you depressed? It's like, that's not the person you have a trusting relationship with on that level usually. So we really have to think about how we do this. And it has to be practical because of busy practices. But on the other hand, I don't know how useful that data is when it's collected that way. So anyway, it's actually, I think, one of the people from City of Hope who's been most prolific in studying the spiritual side of late effects is Betty Farrell. And so, what's in that box about hope and suffering and finding meaning and so on, a good bit of that work is hers. So, but you can see it spans the gamut of physical and psychological, social, and spiritual effects. The other thing that as nurses, I think we have to always remember is who are these patients and what is their background? So we can't ever let ourselves forget the social determinants of health. And I know in pediatric oncology, there are some studies that show that children that come from an environment that is low socioeconomic and so forth do not do as well. So similar to what we're hearing with COVID, that our Black patients and Latino patients do not survive in the same proportions that the white patients do. Why is that? Well, it may be that the same kinds of conditions that are social determinants of health prevail in COVID as they seem to, at least in childhood cancer, and I would think it's true in adult cancer. Certainly when you look at things like delay of diagnosis, access to care, things like that. So there's been kind of, I guess explosion would be kind of too strong a word, but a lot of interest in survivorship. And I just wanted to share with you the first book on your left is the one I gave you a chapter from. And that's really hot off the presses. I think it came out in 2019, if not this year. And it's written by two very reputable adult oncology nurses. And it really is focused on adult survivorship after adult cancer. And then the two on the right are ones that I've been involved with that are both focused on childhood cancer survivorship. The one, A Practical Guide to Your Future, is for patients, it's for family members, and so forth. It's really at a lay level, and the other one is for healthcare providers. The Feuerstein book is relatively new. I actually don't have that most recent edition, but just to illustrate that, there are lots and lots of articles that have been published, but also now books. So I think it's a significant sign of something that's really found its time, its moment. So where this really kind of sparked intense interest, I think, is these two reports that came out from what used to be called the IOM. It's now called the National Academy of Medicine, but I still kind of think of it as the IOM. One came out, the one on childhood cancer survivorship came out in 2003, and the other one in 2006. And they both were really remarkable because they brought experts together and then really published, sort of a pay attention to this. These are the important things to be noticing about and doing about survivorship. So from that, here are the four components, essential components of survivorship care. So it's prevention of new and recurrent cancers or other late effects, surveillance, and then intervention to deal with consequences of cancer and its treatment. And importantly, coordination between specialists and primary care providers. That's huge, and we'll talk some more about that. But so those are the four main components. And what I took from those two books is that there really were some shared recommendations for pediatric and adult survivorship care. And they're these, to come up with clinical practice guidelines and standards and models of care, to conduct research, improve access to care, improve professional education and training, and increase general awareness of late effects and the need for survivorship care. So across the board, pediatric or adult survivorship. So then when you really kind of nail down what the recommendations were, I want to just really focus primarily on a couple. And the first of those is developing clinical practice guidelines. So this is where pediatrics had all that experience from the early 70s onward and through the Children's Oncology Group. So, Kate, I'm not sure adult oncology groups that you have patients on clinical trials for at City of Hope would be things, I guess, like ECOG and SWOG, those things that are familiar to you. So that where your protocols come from?
It's not ringing a bell.
It's probably not as prominent on the inpatient side as it is on outpatient. I think that's true pediatric and adult, that in acute care, you're really not, it's not the priority to know the protocols, but outpatient, those are the recipes you're following for the treatment the kids are on or adults. So in pediatrics, there's now one cooperative group that is responsible for all the clinical trials in pediatric cancer. There still are studies that individual institutions do. So like City of Hope can have studies that are from City of Hope only, but there are, I think, 200 institutions that are members of COG. So they typically are the ones who are determining the protocols that kids will be entered on. So that organization formed from about 4 groups that were present before 2000. And then it came together. So there's this one group. It was an incredible opportunity. I chaired the nursing discipline in that group from when it started. And we had this amazing opportunity to collaborate between the nursing discipline and the late effects committee. And one of the things that we did, and with other committees as well, but this, in terms of survivorship care, was just a fabulous opportunity. So, and one of the things we did was develop guidelines, long-term follow-up guidelines that could be distributed, wherever, and would give some guidance to institutions and primary care practices or whoever about how to follow up after the particular treatment that patient had. So they're set up so that you can look up according to the chemotherapy agent, what are the things to anticipate could be issues, or you can look up according to body system. And then they all have health links, which are sort of lay versions of things that can be printed out. They're not in the sense of evidence-based practice. They're really mostly consensus-based. In other words, the experts got together and said, this is what we agree to do. And then, as I mentioned, that's for consistency for follow-up care. Really, really an important thing. This is not very easy to read, and it's not meant for you to really read it, but to give you the link. So if you ever want to go to it and see, this is a phenomenal amount of work. It was interprofessional work, but nursing had a very strong hand in it. And these are where you find the guidelines, and there are links. You can see, I don't know if I can get my cursor to show it to you, but on the lower left are hypertext links to the guidelines, and the website is listed on the lower right. Just amazing. And they, if you see at the top, we've done them in English. They're now translated into Spanish and French, and more recently into Chinese. So they're in version 5 now. So 14 years of that. I don't know if I mentioned, they're revised every 2 years. So they take certain ones, select certain ones, so they don't do the whole thing every 2 years, but every 2 years something comes up for renewal. And so a task force of people, healthcare professionals involved in long-term follow-up care will update those guidelines. There are also guidelines for pediatric cancer that were done in Scotland, and that the groups from COG and Scotland have worked to try to synchronize. So that work's not only been in the US, but also global. And so I showed where those links were to the late effects summaries, but also where the lay information is, the patient education materials. And so there is one for each of the systems listed on the slide. And that also has been heavily done by nurses. Very proud of that. So it's a little different for survivors of adult cancer. And one of the articles, I'm not sure whether I gave you the article by Jacobs, but I will if I didn't already. But in that article, they say pediatric oncology has taken the lead. The adult oncology community has been hesitant to make consensus-driven recommendations for follow-up care. It just hasn't happened yet. And why is that? Well, there are issues. I mean, who's going to spend the time to do that? All of that work in COG really is essentially volunteer work. It's a volunteer army. All of us that work through COG donate our time. So, that's not an easy thing to do if you don't have a structure for it, for sure. And then, certainly in adult oncology, there's not a lot of empirical data about late effects yet. So that's an issue about what you're going to base your guidelines on. And then I think this is so important. What do we do about workforce? So, there's an increasing number of survivors. That's really good news. On the other hand, there are so many people that are retiring, healthcare providers that are aging out and retiring from oncology and primary care. And so, and others who don't feel at all prepared to provide that kind of care. And there's so much more emphasis now on health promotion and precision health. And again, where do you squeeze that in busy, especially primary care practices? So these are real challenges, and these are real hurdles. So, yeah.
I did read the article. You did send it to me with from Jacobs.
Oh, I did.
But
okay,
I was reading that, and I was thinking, and I was thinking about exactly the challenges you just mentioned. We have the blessing at City of Hope to have survivorship programs.
Yeah, you do. Carla Wilson is a colleague of mine that came from Children's quite a while ago that I know does survivorship care at City of Hope.
If that would, some of them have the, okay. Yeah, and we're still in touch with the oncologists and the hematologists. I can't imagine it would be so hard if it was separate from those providers. There would be such a lack of continuity, I would assume.
Such a brilliant point. I mean, it's really true. In a freestanding pediatric hospital, that's a huge issue. I and a team started the program at CHLA, and that was one of the issues that was really strong, because CHLA is affiliated with USC, but we're not on the same site. And so, in contrast to UCLA, the physician there, Jackie Casillas, started their long-term follow-up program, but they're actually physically situated in the adult care area, outpatient, which is good for a couple things. One is, especially for, adolescents and young adults who, and others that just don't want to come back into an active acute care setting, for all kinds of reasons. I've had mothers tell me that, they got to the corner of Sunset and Vermont and they were nauseated, because of just the association with, so to have it set up where you can really be adjacent, literally, is just, that's everybody's dream. But you're right, City of Hope has a definite strength in that area for sure. A really good point.
Yeah.
So, so I was just going to go back a little bit again to when survival started improving in pediatric oncology. There started to be this recognition of the effects of treatment, especially on growing children. And that's going to be a continuing issue as we start using new immunotherapy agents and so forth. We don't really know what, if any, effect that might have on a growing child versus, an adult that's already finished their growth. So that's an open question. And we began doing studies that were focused on survivor cohorts way back then. One of my jobs a long time ago was to open up this study called 101L, L for late effects, and 101 was the study number for the frontline therapy for acute lymphoblastic leukemia. And it was one of the first studies that really looked at what happened. Did the children have cataracts as a result of exposure to corticosteroids? We looked at cognitive function, looked at growth, because they got craniospinal radiation and so forth. So that was sort of my baptism by fire in a way, because I set up that study and then figuring out, it's not good to do cognitive testing after you dilate the eyes, things like that. It was very practical. So, then what happened was all of those results got fed back into those cooperative groups. When I remember, I said there were 4 before they all merged to become COG. And so the results of those studies got fed back in, and the new questions in those research studies had to do with, can you have the same percentage of survivors if you reduce some of the chemotherapy that we know is really creating complications, or reduce radiation? So, for example, craniospinal radiation for leukemia is not a thing. But part of that was from what we learned in that early study. And I think, to me, one of the things that makes me most proud is that it's the nurses on the front lines, especially the nurse practitioners, and more recently the nurse scientists, since we've had a bigger, sort of critical mass of PhD nurses, have really contributed significantly. There is a long list of publications and so forth. I don't think I gave you the article, but I will if you're interested, that I referenced here. It's now 10 years old, but it has a whole list of what were the studies that nurses led, what were the models of care that nurses designed, and so forth. So, the work has really come primarily in pediatric oncology, because that's where the first really large groups of survivors were. But most of that work has been done by nurses. And so, it's really something we can take pride in. So then, I know I gave you this chapter out of this Precision Health book. It just came out. And that I shared for a lot of reasons, but one of them is because the case study within it kind of illustrates the range of late effects that some of our kids experience. And the particular patient in that chapter, at the time he was seen in a long-term follow-up clinic, was 18 years old, but he'd been diagnosed with a medulloblastoma brain tumor when he was 3. So he got some pretty dramatic therapy, surgery. He had a VP shunt placed. He got some chemo and craniospinal radiation. So the range, I don't want to go through this and read the slide to you, but just the range of neurocognitive issues, hearing loss, all the endocrinopathies. He's certainly at risk for second malignancies, primarily because of his radiation exposure. He's at risk for cardiac disease because of his chemotherapy, and he's at risk for a stroke because of the combination of therapies. So that's a lot. He also has psychosocial emotional risks, and they're listed here in terms of his kind of inability to reach out and be independent, but his frustration that he can't. He's aware enough that he has those limitations. So psychosocially, this is a tough situation. So, and it's tough for the parents. So if, kids get into this young adult age range, and parents are thinking about, well, who's going to look after him when I'm not here, and how, will he ever be able to live independently, or what situation? We don't want to burden the siblings and so forth. So a lot of very complicated issues. And this is a good time to say that's not true of everybody. So there are young people that come through, say, acute lymphoblastic leukemia, where you've got a 90% survival rate, and kids are diagnosed pretty young, 3 or 4 often. They may not remember much of anything about their experience, and then will need to come back and hopefully they're in long-term follow-up, because when they get into a serious relationship, they want to talk about, what is it that I had, and is that something that, they don't know about infertility necessarily. So there are a lot of issues that require re-education at each developmental level. So because kids understand it one way when they're 3 or 4 and another way when they're 6. And so they have to keep relearning it at the cognitive level where they are, developmental level, what happened to them so that they can represent themselves and advocate for themselves in primary care. One of the things we've seen is that it's not uncommon for people who are primary care practitioners to over-attribute problems to a prior cancer history that really probably didn't have anything to do with it, and to underappreciate the things that do come up. So, really important to keep them in long-term follow-up care. Back to that, the whole IOM kinds of reporting, these are the essential components that they felt were important for psychosocial care. And obviously, identifying the difficulties, connecting patients with services is so important. We found to have a social worker affiliated with the team, and because they're the ones who really know where those resources are in the community. Supporting the patients is coordinating their care and providing follow-up assessments. So, so easy to put it in the chart, and it's so hard to actually implement that well in practice, huh? This is Janice Post-White is a colleague of mine and the mother of a young man treated for leukemia. And I think what she said was, I've always remembered her saying that, integrating the reality of risk into who they are and how they care for themselves without letting cancer define them is one of the most important lessons on this journey. And she's saying that about someone who was diagnosed as a child, but I'm really thinking this applies whatever age. There are lessons on, and it is a journey for sure. So now we come to the other one I wanted to emphasize of the IOM recommendations, which is providing a care plan. Tell me a little bit about what you did for your care plan that you're going to talk about. Kate?
Actually, it's funny because you just talked about it. I actually took the case study of Easy, the 17-year-old with medulloblastoma, and I filled out the template for long-term care. But I liked how that really, I didn't have a specific patient to go off of, so I just used him. But I liked how that article really highlighted all the different areas and what to kind of have on the forefront of your mind of what to assess for and think about, and how the treatments have affected everything from the endocrine to hearing and then what kind of cancers he's at risk for. So it was just interesting in my mind, I was thinking, okay, so are there survivorship, just to know this type of cancer, here's all these risk factors that they would be at risk for, to assess for. So that's kind of how I was thinking through the treatment plan. So it was interesting. Yeah.
Oh, that's great. That's really great. Nice to hear.
That's amazing, Kate, that you used the care plan that Kathy had. Awesome.
Synchronicity. That's really great.
And Kate, I want to tell you, sometime, I'm not sure if it's me or you, but it seems like your internet kind of cuts in and out a little bit. Do you hear that too, Kathy?
Yes, from time to time, a little bit,
All right.
Is that
so we
me?
might have to we just might have to ask you to repeat yourself or something. Okay.
Yeah.
You're coming through.
Oh, okay. Yeah, it froze up a little after I talked. Should I disconnect and reconnect? Jill?
Where, I don't know if it's where your internet connection or your box is in the house, like maybe you're too far away from it. You're on Wi-Fi?
I might just have other people on using the internet and I'll tell them to turn it down or turn it off.
Okay. Yeah, now, the way you can tell is like there's little bars next to your name, and I see that they're yellow and sometimes they're red. That shows me how good your connection is. And right now it's white, which is perfect.
Okay. All right. Well, let me know if it's red and I can try to reconnect. Sorry about that.
Oh, no problem.
No problem. Just holler if you need to.
Okay.
Okay, so there, I agree. Really, that's very cool that you picked easy for your care plan. I love it. So I wanted to just make a distinction between the treatment summary and the care plan or wellness plan. Sometimes they're put together, but not always. And so the two columns here kind of show what's included in each. And you know, the treatment summary is pretty straightforward in terms of, you know, giving a way for the individual to have a real record of what they were exposed to, what their treatment was, and so forth. We found back in the day that so often, you know, there were occasional families where usually it was the mom, but she'd come in with a big notebook, a big three-ring binder with, in those days, lab reports, you know, taped in there, and, you know, had kept an entire record of the whole experience. If you've seen what the beads of courage are, they're mostly used with kids, but they're different color beads for the different experiences, like having a lumbar puncture is one color and having, you know, et cetera. It's kind of like the beads of courage version of that, only in a notebook. So it became clear that, and in the hospitals, there was a point where they were purging all paper medical records back before a certain point. So, you know, if you're encouraging long-term follow-up in young people who are now 18 and were diagnosed when they were 3, and the hospital's getting rid of, you know, the medical record, that's a problem. So for all those reasons, we really were interested in developing treatment summaries. The wellness plan is really sort of the looking forward piece, and especially in terms of health behaviors and what are the screening tests that are needed and how often, and how to tell if you're, you know, if there are signs of a recurrence or a secondary malignancy and so forth, and how to do that without inducing so much fear that it's paralyzing, I think is, you know, the other piece of that. So it's always about, at least in my perspective, information, but also managing fear. Because the undercurrent for many, many people, if not most, is, oh no, it's back. And I've had parents tell me that, you know, their adult children went off to college, and, you know, when they call home and say they weren't feeling well or they had a cold or whatever, even then, that many years later, the parents' first thought was, oh no, it's back. And so, you know, that really can be pretty haunting. So let me talk a minute about what we did back in the day. Wendy Hobby, who is a nurse at Children's of Philadelphia, was setting up the long-term follow-up program at CHOP while I was working on the program in LA. And we decided we needed something, you know, to give these young people so that they had a record. And this is not even the very first version. The very first version had a tree of life on the cover of it and stuff. And it was, it was all we had at the time. And we actually started it in the late 80s, I guess. And as you can see on the bottom of the slide here, revised it for a while. And then the version that's shown here was a tear out in the Survivor book that I showed you earlier. So, we were still working with paper records. There are now much better resources, and I'll show you some of those. Oh, but I was going to say, funny thing, when I was at Children's, one of the cardiologists who was very interested in long-term follow-up after cardiac surgery in infancy and so forth, said, that long-term follow-up thing you have? She said, we want to copy it for the cardiac patients. And I said, well, absolutely, go right ahead. So she cloned it for a different population entirely. So this is something in terms of adult patients that I think is a good resource to know about. And it is OncoLife, which is Penn, and I think it's also the ASCO, Association for Society for Clinical Oncology. But you can see the yellow bar in the kind of the lower part of the center of the page, develop my cancer survivorship care plan. So clicking on that, a person can put in what they know and can develop a survivorship care plan there. And they can do the same, they can do that with the treatment summary and so forth. And they can have their healthcare provider add to it or start it, either way. So it's a very useful thing. And then it's, it's in the cloud, so it's they're not going to lose a piece of paper and so forth.
That's great.
And so, I think so too. And this is one example of format. There are others, but it's not a nothing for somebody to fill out, review the chart and then fill out the form, or either way, whether it's on computer or on paper. So we always found that the preparation for the long-term follow-up appointment was considerably longer than the actual appointment. And you have to figure that into staffing. So if it takes a nurse practitioner 2 hours to abstract a medical record, which it could, you have to account for that time. So anyway,
Sure.
that is a challenge. And then in terms of, did I skip one? No. In terms of pediatric survivors of childhood cancer, this is another electronic resource. Again, user-generated, but you can also have your long-term follow-up clinic or healthcare provider put in the information that's medically accurate and so forth. So that's the link I have given you there for Passport for Care. And this is just to give you a little more information about what's on there. So if you look on the left, kind of about a third of the way down, those are all hypertext links to more resources, information about current survivorship research, survivorship stories, happenings around the country, et cetera. So it's enriched with some good information and really reinforces the encouragement to survivors to be seen for regular follow-up care. And so this is to remind me again that we didn't know what we didn't know in the early days, and I think that it's still true. We really have to listen to the voices of survivors. This is a young woman who was treated, I don't remember the year, but when she was about 7 or 8. And then the picture of her was as an adult. And she talked about wondering whether some of her health issues were normal or were they related to the cancer. And so she was a very strong advocate of the long-term follow-up program because she felt that it helped her sort through some of that. And then, we couldn't do this without talking about research. So this this cancer survivorship research graphic is a lot on one slide, but just to talk about all the possible gaps and areas of focus for research, both the survivor's experience individually and then interpersonally, the healthcare system factors, the community when I was talking about, social determinants of health, and then policy factors. So there's lots and lots of research that's been done and lots more that needs to be done. In pediatrics, this is one of the most amazing stories, I think. So I have a colleague named Les Robeson. When he was getting his PhD, he is actually the person who wrote the protocol for that study that I said I implemented, 101L. Well, it was implemented all over the country. But that's how he got started. And then in '94, he wrote a proposal for a multi-institutional study that's now based at St. Jude. And that's referred to as the Childhood Cancer Survivor Study or as the Long-Term Follow-Up Study. Since 1994, they have consistently followed one cohort of childhood cancer survivors, of 14,000 of them. They were all treated between 1970 and 86, and they had survived at least 5 years before they were entered on the study. And it would be hard to understate the importance of this study. Many, many studies under this umbrella that have really driven the data that's available, the evidence base for childhood cancer survivorship. I put there one nurse PI because in the very beginning when this started, that was me. And it still is. I'm still on the education committee for this study, and I'll show you what we're doing right now. It's really pretty cool. So we do a newsletter quarterly, and that goes out electronically and also by old-fashioned mail. And then they got a grant to develop an app that's called My Long-Term Follow-Up. And I just gave you a screenshot of what it looks like on my phone, but it's really been an interesting process to develop that so that there's accurate information available, but it's not, hopefully, fear-inducing. And it keeps this cohort engaged in the study and, periodic refreshers of the study. So, figuring out what's the incidence of breast cancer in members of this cohort who were treated for Hodgkin's disease and had radiation of the chest, for example. Those are really important pieces of the whole survivorship question. And so they've worked really, really hard to keep these participants, these 14,000 people engaged so that they can continue to complete surveys every couple of years and so forth. So it's really an amazing phenomenon. And so that takes us to, what are the challenges going forward? Kate, I bet you can already name them all. One of the most important things in that Jacobs article, it says it's not easy to change a paradigm in which providers have historically focused on cancer treatment and cure. Absolutely true. I will tell you, at a follow-up appointment of my own, I was asked, are you having any issues that, are concerning to you? And I said, yeah, fatigue is a concern. I have to really figure out how to best use the time when I have the most energy, and I have to budget my time. It's not insurmountable, but it is a concern. And Fortunately, I had a friend with me, so I had a witness, and she said, yes, that is really what she said. She said to me, I don't know why you'd be fatigued. You're not in relapse. So I think, you know, but that's a busy acute oncology practice. What they're focused on day in and day out is, you know, writing the orders, making sure the right chemo gets given, and, you know, do we have to delay based on what's going on with this or that? So, you know, it's understandable, but it means we've got to do a better job somehow of helping people that are no longer on active treatment, but still need surveillance and need, you know, need guidance. So how best to do that? We talked a little bit about is, you know, what do you do when you're in a freestanding, you know, children's hospital versus, you know, elsewhere? That whole issue of how to manage transitions and how is the communication between providers in the pediatric setting and the adult setting. Are adult providers willing to take survivors of childhood cancer? You know, that's always an issue too. That emphasis from acute to chronic and from subspecialty, then what do primary care physicians do? You know, without any specific education about long-term follow-up care, you know, that's really a difficult burden. And the other thing is that you have to have available expertise from various specialties. So cardiology, pulmonology, GYN, neurology, GI, that's a lot. In CHOP, one of the things that they've been doing is they set up a clinic where they have, I think it's 1 day a month, and they book people from the different specialties, and the patient comes and goes from room to room. And so the specialists are all there, and then they have a team conference, so they discuss the plan, which is a really interesting concept, you know, that they've been trialing. And the other thing is, we know how hard it is to do effective health education and health promotion for anybody. So it's no different for survivors. We talk about teachable moments, and I think that Patty Gantz in that one video talks about, you know, people are questioning, what can I do so this doesn't happen again, etc. Nevertheless, it still is really difficult to change behavior. So, and then I think the big question right now is, and how do we do all this and deal with COVID? You know, it's such a surreal time and so stressful on everybody, and everybody's stretched to the max. So I don't have answers, but these are some of my questions. So what are we going to do going forward? Any thoughts on that? Were there other challenges that you kind of picked up on?
I think you kind of captured the ones that stand out, but yeah, I think you know, they're all my same questions too, and we are in such a surreal time in COVID that
yeah, it's really hard to think beyond that.
I know, yeah. And I think a lot of the survivors and the survivorship work, I mean, I'm sure a lot of it's being suppressed right now because it's not the most pressing issue, you know? So.
Yeah, I agree. The latest issue of that newsletter from the survivor study, I just got the rough copy, the first draft, and there's an article in it where one of the other people on the committee and I are talking about using telehealth, and she's at, I think where she is, I think Chicago, and she was saying that, you know, they've been converting a lot of their survivorship care to telehealth because so much of it can be done without a real physical exam. And so in order for their survivors not to drop out of follow-up care altogether, they've been doing a lot of telehealth. So, I think that's one strategy to try to, keep people engaged. There is, I believe this is still true, that childhood cancer survivors who are the most engaged in follow-up care, but even among those, I think it's only 30% that are actually seen for follow-up care. So that's a huge issue. How do you reach the hard to reach?
Mm-hmm. Sure.
So this is my take-home message. It's not over when it's over. One of the mothers of one of our patients said this to me a long time ago, and she's right. There's so many echoes and repercussions and things to deal with, even after treatment ends. I like sort of coming back around to this. Susan Lay is another one of the founders of that NCCS with Dr. Fitzhugh-Mullen. And she said those who thrive after cancer are able to put life and death into perspective and consequently create a special place for their cancer experience within their personal life history. She is a 3-time cancer survivor. Pretty amazing.
I know that Brad Zebrak, who it's a photo courtesy of him, he does a lot of the research right on psychosocial aspects of survivorship. See his name a lot come up in articles.
Yeah, his background is in social work. Yeah, really, really wonderful guy. He's done a lot. So, and just to end up, I think the next time that I come back to your class, we'll talk about models of care and the role of the advanced practice nurse. And that's a sign that I saw when I went to SC. The Life Clinic is the clinic I started at CHLA. So then I talked to the physician who now runs it, David Fryer, and I said, so I saw the sign. He said, yes, your baby has grown.
Oh, how rewarding, Kathy.
Yeah, isn't that cool?
Great.
Yeah, that was really fun. So I'm happy to talk about any or all of it, or questions that you might have or whatever.
That was really terrific. Thank you so much for bringing all this information here. One of the things that I've been kind of looking at from a researcher lens is, when we have all these models of care, or we say, this is better than that, and this distress thermometer is great. I always ask Kate and Dixie, like, yeah, but when you're actually as an NP, how do you use this stuff? And I see it maybe as being evidence to support what we do, as more than I see it as actual interventions that are translated into care. So I guess that's just kind of a perspective of how I see it. I think if you see like a model of psychosocial health or something like that, when you're actually seeing a patient, we talked about the limited amount of time we have to see. So how do you, the research shows that we should be checking off all these psychosocial well-being domains. But is there, I guess it's just hard. I would see it as hard for Kate and Dixie as NPs to meet all of that. And so any suggestions about the best way to use research and translate that into care?
That's such a good point, Jill. I think that it concerns me that a lot of these scales that are being implemented, the data is never used. And so I think that's one thing. We really ought to be using data to better understand what our practice is. That's one thing. I mentioned the other thing of just how are these administered? I think we need to really question, is it, for efficiency that it is the MA who's administering?
Right.
Really, because it comes back to it's all about relationship. And so if you're talking to a patient in the context of a relationship you have over time, I think it's so different than just plopping down, here's a questionnaire. So, one of the things that I would share that I think is still in the research domain, but with several other people, we put together a proposal for PCORI maybe 4 years ago or so. And it was to use an iPad to give questions about how a relatively newly diagnosed patient likes to make decisions about things. And it didn't get funded, unfortunately, but the idea was the technology is there to do this. And you could send that results of that questionnaire immediately to the person, the nurse practitioner, seeing that patient. So that by the time the nurse practitioner sits down with the patient and talk about, okay, I can see that, when we talk about what the treatment plan is going to be, it's important to you to have your partner with you or whatever. And so, some of those things are things we could look at and really drive the research and into practice for the things that are really in the nursing practitioner, nursing domain. So I would love to see some study similar to that done at some point. But I think you hit on something where it's just a matter of checklists only, and it's not about the relationship, the human relationship. I think that's less than satisfying for both. And I do question the quality of the data that comes. I have several friends who have said, they asked me about depression, and the first time they asked me, I said, my daughter died. I'm feeling pretty sad. And from then on, her record showed that she was depressed, and she's pissed off about it. And another one who said, what? I don't want to go into that. I will never answer that truthfully. So, I think we can fall in love with lots of checklists and things because we're nurses and we like lists and, organization. But it's worth questioning what we're doing.
We had a survivor talk to a 12-year-old renal cancer survivor talk with us last week? Was it last week or 2 weeks ago?
2 weeks ago.
Yeah. And he was talking about how his oncologist was like this Superman oncologist, and he actually met with the patients before their scheduled appointment using, was it telehealth, Kate? Or called them up and just said, okay, like what?
Call, yeah.
So phone call, look over the labs, go over everything beforehand, almost like a flipped classroom. And then when the patient came in, they were just diving into what was so important. I thought that was just fascinating.
Oh, that is fascinating.
Yeah.
Really interesting.
Recall. Seems so simple, right?
Yeah.
Yeah.
Yeah. Make
it really
a huge difference.
Yeah, it allows time to really dive into all the other issues and, side effects and how the patient's really doing and how the family's doing with dealing with it. So, yeah, it's amazing. He's an amazing physician. Yeah.
I could see that following some kind of like motivational interviewing model where you say to the patient, what's up for you now? How confident are you, or how concerned are you about this? And really going to what matters for them.
Yeah.
I think that's wonderful.
Kathy and I are going to work on some oncology research, so maybe we could do something like that.
Maybe we can. That would be great. That would be wonderful.
Well, and you can
So
see
that's
with
great.
with doctors like Dr. Powell, which was his
Mm.
oncologist, how some patients don't want to give up their oncologist as their or use them as a primary care physician
Such a
because they
good
have such a
point.
close relationship. Yeah.
Right.
Oh, that's
Yeah.
really good, Kate. I should have mentioned that. That's really an important issue, both ways. You know,
Sure.
for many healthcare providers, the patient that survives is a real totem. You know, you don't want to give up that relationship because that's a success story for you. And the patient has the trust that's built over time. So, and they don't want to leave that physician or nurse practitioner. So, yeah, really good point.
Absolutely.
I think this whole COVID thing is really propelling us into a whole different era of using, technology and leveraging technology. That's the buzzwords now. So,
Yeah.
yeah, it'll be interesting to see what comes out of this, and or people will look back and say, oh, healthcare before COVID and healthcare after, or oncology care before and after.
I think so too. I think it's going to be a real turning point. Without a doubt.
When I worked as rapid response, I did both inpatient and outpatient, and it always amazed me how patients would have appointments all throughout the day, these long days, of radiation or labs or, scans, and then they see the physicians and they're on campus all day. They're fatigued as it is, they're weak, frail, and then we're putting them through this, long day of appointments. And so many times I had rapid responses on outpatients just because they would fall, or they would, just pass out, or whatever it was. But it always amazed me pre-COVID. Why can't we do some of this, telemedicine? Why can't we have them be at home for a lot of this? We just put them through the ringer just because that's what we've always done. But if they could just stay in the comforts of their home and, not risk falling and passing out, I think we could benefit. So there's definitely pluses and minuses, but it's always something I thought about.
But so much could be done that way. And if it will be reimbursed now, I think that's really revolutionary. That's good.
Absolutely. Yeah.
On the other, there is a flip side to that, though. And I think, there is a social aspect to coming to clinic or being in the infusion center or day hospital over a period of hours and seeing the same people, each week and so forth. It's kind of the same thing we found, and maybe you have too at City of Hope, when we put up the new inpatient tower at CHLA. All the rooms are single bedrooms, or virtually all. And one of the things we noticed was that the families just cocooned in the room. And so there wasn't that interaction and the support that used to come from them, seeing each other in the hallway and so forth. So, there's that too.
Sure. Yeah, absolutely.
Yeah.
Think about the patients who went through bone marrow transplant and had to be in isolation for so long. They already did all this, right?
I know, it's true. It's true. Yeah, I've said that to a lot of people, that people that have had a child that went through a transplant or even, just active chemotherapy where you're really restricted in terms of your counts and stuff like that. It's a rehearsal for sheltering in place.
Yeah.
So, anyway.
Well, this has been great. I really appreciate you being here. I think we already looked at your care plan, Kate.
Our patients, there's yeah. Sorry, I didn't hear the last part of what you said.
I bet maybe it was me that cut out. I think I have. Oh, but I was just saying, I think we're all set. We looked at your care plan. I'll look at it on Canvas a little bit more. But I think we're all set. We have great resources from Dr. Ruccione to look at. And so that's part of our classroom time, of course. So I think this has just been so meaningful and wonderful. It's so great to have you.
Well, what a fun small group to join. Thank you so much for having me. It's just been wonderful.
Thank you.
All
Thank
right.
you so much. I definitely learned a lot, and I appreciate all your resources. So thank you.
Oh, I'm so
It's very
glad.
nice to meet you.
And we'll
Great
see
to
you
meet you
next a
too.
couple of weeks.
See you in a couple of weeks.
Okay.
Wonderful.
All right.
Good night,
All right.
guys.
Bye.
All right.
Bye.
Take care.
You did a great job, Kathy. That was wonderful.
Oh gosh, thank you.
Loved
Thank
it.
you. Thanks for